Welcome to our symposium, Medication-Related Fall Risk in Older Persons, Update of the Evidence. My name is Lotta and I'm the chair of the session today. I'm finalizing my PhD at the University of Amsterdam. This symposium is being organized by the World Falls Guidelines Working Group on Polypharmacy and Fall Risk Increasing Drugs. This working group is being led by Professors Mirko and Professor Nathalie van der Velde. Also, the EU GMS Task and Finnish Group on Fall Risk Increasing Drugs has helped us to organize the symposium. You can find all the relevant information related to this working group on their websites, such as their outcomes and objectives. Today, we will have 3 presentations. The first one is a sneak preview of the World Falls Guideline recommendations, and it's about the importance of a structured, comprehensive, and personalized approach when deprescribing fall risk increasing drugs. The presentation is being given by Professor Nathalie van der Velde, who is a professor in geriatrics at the Amsterdam UMC, the Netherlands. She is also a co-chair of World Falls Guidelines Task Force and EU GMS Special Interest Group on falls and fractures. She also chairs the EU GMS Task and Finnish Group on Fall Risk Increasing Drugs. The second presentation is being given by Dr. ALPANA Mair. She will talk about effective strategies in deprescribing in older persons, how to develop a transmoral, multidisciplinary and personalized care pathway. She's the head of prescribing and therapeutics for Scottish Government. In addition, she's chairing National Scottish Polypharmacy Guidance and Delivery and leads a European-funded project iSympathy. And among others, she's the vice chair of World Health Organization Systems and Practice Group on Medication Safety. The last presentation is about deprescribing dilemmas, how to approach hypnosedative deprescribing in older followers. This presentation is being given by Professor Mirko. He is a full professor and chairman at the University of Ghent and leads the research unit Quality of Drug Utilization in Older Persons. In addition, he serves as the president-elect of the European Geriatric Medicine Society. He has over 300 peer-reviewed articles in the field of aging and clinical pharmacology and over 130 international presentations as a guest or keynote speaker. I hope you enjoy the symposium.
Thank you for the introduction. So I will be discussing the role of fall risk increasing drugs in falls and how to deprescribe them. And this will be in part a sneak preview of the World Falls Guideline recommendations. As you may have heard from the presentation of Professor Manuel Monteiro Dasso, since 2019, there is a task force that is developing a clinical practice recommendations for the prevention and management of fall risk increasing drugs. And today I will be partly discussing the work of Working Group 2 that addresses polypharmacy and fall risk increasing drugs. And this is led by, among others, me and Mirko PETROVIC. So to get back to the topic. We are in an aging society, as all of you know, and with aging comes the occurrence of chronic diseases. And at this point in time, at the age of 65, approximately 50% have one or more chronic diseases present. And this goes up by 3 or more diseases by the age of 75. This multimorbidity is often accompanied by polypharmacy. And these drugs are, of course, meant to treat diseases and symptoms, but more often than we assume, they result in adverse drug events like falls, which we, of course, want to prevent. So I've shown you that falls are a common adverse drug event. And in fact, if we turn it around, drugs have also been shown to be a major fall risk factor. Currently, approximately 90% of fallers use one or more fall risk increasing drugs. Thus, it's very important to recognize falls as a potential adverse drug event, but in clinical practice, this is under-recognized currently. The next question, of course, is should we recognize it? Can we do something about it? Well, as you may know, the common approach of falls prevention is to address all potential treatable fall risk increasing factors using a multifactorial intervention, and this indeed lowers fall risk. But if we're talking about medication, it's more important to actually look at the effective components that a recent network meta-analysis has provided by, among others, Doutzenberg et al. And this shows that, non-surprisingly, exercise is part of the effective interventions, also assistive technologies, environmental assessment, quality improvement strategies, and the basic fall risk assessment, which includes a medication review. And what it also showed is that if we're looking at preventing fall-related fractures, the basic fall risk assessment, including the medication review, is already effective as a single intervention. So it has been proven that withdrawal of fall risk increasing drugs is effective as part of the falls preventive intervention. And there's been other studies that it also can be safely done. But in current practice, we have hard time doing so. And this, one of the questions we have there is, which drugs should we withdraw and in whom? To this end, a few years ago, the European Task and Finish Group on Fall Risk Increasing Drugs has performed a systematic review and meta-analysis of publications out there on the association of drugs with fall risk, and this was published in JAMDA. So here you see a summary of the outcomes. Given the time, I won't go into details, but as you can see, all psychotropics are, as we probably all know, related to fall risk increasing drugs. Interesting is that it's not only about the overall groups, like for example, antidepressants, but it's also true for the subgroups. And we very much know that tricyclic antidepressants have a high fall risk, but it shows that also fall risk is increased for the SSRIs. And something similar is seen for benzodiazepines. It's not only the long-acting benzodiazepines that increase fall risk, but also the short-acting ones. For cardiovascular drugs, we see another picture. There we see that there appears to be no significant effect, or even maybe a little bit protective, and the only significant effect is for loop diuretics. I'll come back to that later. For the other medications, you see there's a significant association between falls and antiepileptics in the adjusted meta-analysis, opioids and polypharmacy. If we look a little bit deeper into the medication for cardiovascular diseases, we see that there's differences between drug properties. So there was no effect on diuretics overall, but there was an effect on fall risk for loop diuretics specifically. And even it looked like the thiazides were protective. But this may be caused by the fact that thiazides lower fracture risk, they lower osteoporosis risk. So it's probably not a falls preventive effect, but a fracture preventive effect. So we should really think about drug properties. And something similar occurs with beta blocker agents. And this was seen in the descriptive synthesis. They appear to be protective overall. But in a subgroup of non-selective drugs, beta blockers, it was actually fall risk increasing. So again, don't look at the big overall groups, but assess specific drug properties. And very importantly, systematic review efforts have serious limitations. They're restrained to commonly prescribed medication classes and pharmacological groups. And in clinical practice, specifically for older patients, we often treat for drugs which aren't commonly prescribed, so it can't say much about that. And moreover, it doesn't say anything about the individual treatment effects, it says something about the group effects. So I'll get deeper into that later. But I want to start with that to this end, to get a better list of which drugs are agreed upon fall risk increasing. With the European expert group, we have as the first group, build a European FRID list, which is called the Stop Falls. And this was done through a large Delphi effort. Here you see summarized again for time, I can't go into details, which drugs are agreed upon fall risk increasing, and this includes all psychotropics, but for the cardiovascular, the list gets bigger. It's central antihypertensives, it's vasodilators, it's alpha blockers, antidiuretics. And for the other groups, it also, besides the opioids, includes the antihistamines, alpha blockers for prostate hyperplasia and urinary frequency and incontinence medication, as well as anticholinergics. And it the stop fall tool didn't only say something about the list, it also gives more detail on how you should deprescribe and when, and how this follow-up should be organized, which symptoms we should monitor for, because this is really something that in current practice we struggle with. And this decision tool, which is also digitally available, I'll show you a link to that later, is based on a decision tree for fridge management that was developed by the UNGM as Task and Finish group in 2019. And it takes you through the steps of deprescribing. So if there is a fall risk increasing drug, first of all, you look for an indication. If there is an indication, you look for a safer alternative. If there isn't one, you apply shared decision making with your patients to make sure we treat for the goal that the patient actually has, which might be live as long as possible, but it could also be symptoms reduction or falls prevention. And then you decide together with your patient and possibly another specialist whether to continue same or reduce dose or to withdraw. And when you withdraw, you really need to not stop but monitor symptoms. So does fall risk and related symptoms actually go down? And also does withdrawing the drug have a possible negative outcome for which you should prescribe? And this is important for several reasons. And of course, in general, quality of life and disease prevention, but also in the case of falls prevention, because falls are often multifactorial and several diseases may increase fall risk. And I give you the example of the cardiovascular drugs. The cardiovascular drugs may increase fall risk, but on the other hand, the cardiovascular disease also increases fall risk. For example, rhythm disorder or poor left ventricular function with, for example, heart failure. So we really need to treat as good as we can the cardiovascular disease with as little as symptoms as we may have from the medication. So this is sort of a balance that we need to find, and we need to find it together with our patient. And when we're making that balance and we're making that decision, there's been several papers that are also other interactions need to be taken into account. So it's been shown by, among others, Nathalie and her group that the risk of falls in the use of cardiovascular medication is dependent on specific patient characteristics, which includes earlier falls, the gender, is there presence of frailty, is there presence of multiple chronic conditions. And also she showed, as others did, that the risk of falls goes up with the intensity of the prescribing. So the more and the higher dosage and the more medication, the risk goes up. And something similar was seen in a large Medicare claims data set, but this wasn't significant. What they did very strongly see is that also in this group, presence of frailty was an important predictor of fall risk due to antihypertensive. So frailty is a personal characteristic that needs to be taken into account when you're deciding whether or not to deprescribe. So if we come back to the stop fall list and the accompanying deprescribing tool, here you see a paper example. Please don't try to read it. It's lots of text, and you can find the details in the Age and Aging paper or the digital version at our EGMS SIG page. But to give you an idea what it doesn't only say, okay, it's an antidepressant, so you need to consider deprescribing. It says, so if you deprescribe, how you should do that. A stepwise manner, weekly changes, how low the dosage should be lowered per time. And also it says that if you want to deprescribe, when should you do it? Which symptoms are most likely to lead to falls? Which reasons make it easier to decide on stopping? For example, in this case, for if the depression was only there for one time, etc. And then the next step after you've withdrawn, it also informs you what to monitor for, how often, but also which symptoms. Symptoms are related to falling, but also symptoms relating to reoccurrence of the disease. So it's a very detailed and helpful tool. To give even more support and help, the European Task and Finish Group is also developing a clinical review series that gives an in-depth reflection for important FRITS groups on indications to use these drugs, but also on reasons to deprescribe. So which symptoms would make you deprescribe for which subgroup. And it advises you also on which alternative you could consider. And I can't show you all, but just one table that can be found in all of those reviews. And this one is on the antidepressants one. Again, don't try to read it. It's just about the big idea. You can read the paper later, I hope. So here you see all the antidepressants. It's the groups, SSRIs, NSRIs, etc. But it's also these specific drugs. And on the horizontal axis, you see the pathways that may lead to falls, for example, orthostatic hypotension or dizziness or extrapyramidal symptoms. And what you see here is the prevalence of those symptoms in the specific drugs. So if you have a patient with orthostatic hypotension leading to falls, you can, and they are using amitriptyline, you're sure that this is probably related to it because it's a high prevalence. And if you do want to continue with an antidepressant, but you want to change, you can look on the ones with a lower prevalence and try see if this would be a good alternative for your patient. And this will be done for all specific fall risk increasing drugs groups. There's 2 reviews published now, and the rest is expected in a special issue by the end of this year. To summarize, when we're deprescribing in general, but very much also for falls, we need to take a personalized approach. And when we do this, first of all, we really have to take into account the goals and wishes of the patient, because the guidelines inform us on the effectiveness for the main outcomes of the trials, which are often prevention and of death or main cardiovascular events, which may not be the same as the wish of the patient, who may want to stay functionally independent or something. Then, of course, we have to look at the indication, we have to look at the disease severity, we have to look at the fall risk, we have to look at comorbidity, we have to take into account other fall risk factors, symptoms and potential adverse drug events, interactions, and frailty and life expectancy. So this brings me to our draft recommendations, which are, of course, a little bit changeable still. So we recommend that medication review and appropriate deprescribing of fall risk increasing drugs should be part of the multifactorial falls preventive intervention. And this should really be done in a holistic approach, so we get a good view of the patient and all the things I just mentioned, the multimorbidity, the frailty, etc., to stratify for overall fall risk and the expected effectiveness of the withdrawal. And then to help do this, because it's really a complex intervention, we advise to incorporate a medication review tool to systematically identify medication-related fall risk in older adults to optimize deprescribing and apply the use of a personalized strategy, taking into account the older person's values and preferences and individual characteristics against comorbidity, frailty, status, and setting. So here you see the online version, which I promised, of the Stop Fall tool, which you might use, but you can also, of course, use another tool. And this is the link to the online interactive tool. This brings me to my take-home messages. Falls are an important and under-recognized adverse drug event. So to the same, the multifactorial falls preventive intervention needs to contain a medication review. And regular medication reviews should be done in older and specifically, and moreover, and even more in frail older patients, at least yearly or more often. And when you're deprescribing, really, there's a need to take a structured approach. And for falls prevention, you could use the Stop Fall tool. When you deprescribe and consider deprescribing, please take drug-specific properties into account, take interactions with diseases and other characteristics into account, and invest in education and patient power empowerment so that you can perform adequate shared decision-making with your patient to come to the right decision. Thank you for your attention.
Hello everybody, my name's ALPANA Mair, and thank you for the opportunity today to talk to you about effective strategies in deprescribing, taking a person-centred approach to address appropriate polypharmacy. So it's important that we think about what the care of an individual might look like. If you look at the graphic on the left-hand side, you can see what a typical week might look like for Malcolm and his carer, Barbara. You have all these different people coming in to provide care for Malcolm. And these different people may also decide to prescribe for Malcolm, and the complexity that this will then result in the medications that might be prescribed and the lack of coordination. And what you can see on the right-hand side is an individual trying to make sense of the treatment burden of taking multiple medicines, using a compliance aid in order to try and put these into some sense that they can remember to take them. But if you look very carefully, you can also see that what's being used here is that the device is being used to decant medicines. And so if a social worker did come in and try and address this, this would result in harm to the individual patient. So what would good coordinated care look like for an individual? It would really be where the care is planned with people that would work together to ensure that the care is coordinated, putting the individual in control of their treatment and their services to get the best outcomes. And that includes medication, so that one healthcare professional that's prescribing for an individual person will think about the impact that might have on other medicines that are being prescribed for them. So from a healthcare professional perspective, it's making sure that we combine all the parts to form a whole so that it's integrated, so that care is optimizing. So making sure that as a person moves across care transitions, we undertake a medication review. We make sure that the lists are accurate for the individual. So if they're moving from the hospital to a care home, for example, that this information is shared. And indeed, if they go from the care home back home, that we think about what the individual might need in order to manage their medicines at home, and if they still need to take the medicines and at those dosages. If we're going to implement such a system for patients to allow them to do that, we need to design a system across the whole health and care system that takes an integrated approach, and making sure that there's innovation in that by having the multidisciplinary team of the doctor, the pharmacist and the nurse, with the patient in the centre, and including policymakers, commissioners and educators as part of that leadership team to make sure that policies get implemented and are sustained in practice. One of the areas that's really important to address if we're going to have an integrated, a whole system and a person-centred approach is to make sure that the culture is right, to make sure that it's okay for individuals to challenge prescribing that may have been initiated by another healthcare professional, because our goals are to do it in the patient's best interests, acknowledging that circumstances may have changed for the patient, evidence base may change, and therefore a change is warranted in the treatment. So what I'm going to talk you through is a 7-step person-centred approach that will help us look at how we might address this. So starting with what matters to the patient and making sure that we take into consideration lifestyle choices that may be important in terms of consideration of treatment, to make sure that we have the right medicine, we don't have any unnecessary medicines, and the medicines that we use are effective and not causing any harmful side effects. We know that up to 11% of all hospital admissions are due to medication-related harm, and that half of these are preventable, with 70% occurring in those over the age of 65 or more. So this is really important. Making sure that treatments are cost effective so that where possible, patients are not having to make decisions about taking treatment or not. So affordability is really important. And coming right back to the patient and agreeing and sharing the plan, making sure that they're comfortable with the medicines that they're taking, We know that 50% of patients taking 4 or more medicines don't take them as prescribed. So we need to make sure that patients are on board. So to illustrate this process, I'm going to take you through the case of Mrs. P, and you can see very briefly, I'll just allow about 30 seconds for you to take note of the main points here. So Mrs. P has back pain, asthma and depression. She takes a variety of different medications, complaining about pain and drowsiness, had low mood since the breakup of her marriage, but right now is going through quite a number of inhalers and complaining about poor sleep and breathlessness. So what's the objectives of the treatment here? So identifying the objectives of the treatment, thinking about, is it the management of existing problems or future health problems or prevention? And that's really important to do that in the context of finding out, well, what's important to the lady here. So the patient reports that they're constantly in pain, but especially when they get up from the chair, they can't catch their breath and need to use the salbutamol inhaler frequently. So we can deduce from this that one of the issues that the patient is complaining about is pain and asthma management. And we can think about smoking cessation here, but we obviously need to place that in terms of the lady's priorities. In order to take a person-centered approach, and if you remember back to the quote from the patient group right at the beginning, patients want to be involved. So shared decision-making is crucial. So these aids that you can see on the right-hand side using the Kate plot, so pictorial representation about the likelihood of benefit from the medication, but also the likelihood of harm. And this helps illustrate to the patient how much benefit they're going to get from a treatment, what the possible side effects might be, so they can make an informed choice. Looking at the picture on the left-hand side in a care home, it's also important that we speak up for people that are not able to speak up for themselves. So thinking about the appropriateness of treatment, such as antipsychotics and hypnotics in some settings, is really important as well. So having good decision support toolkits is really important. And through the link, you can see and download this toolkit. So there's information for healthcare professionals, for patients and carers, where some of those shared decision-making tools can be found. And then also drilling down and looking at specific medications, such as benzodiazepine, that our lady here is taking. So we may then want sort of a plan in order to help her stop deprescribing. And one of the later talks is going to talk about that. So moving on then and thinking about, well, what's essential treatment here and what's unnecessary. So it's important that we don't stop medicines that have a essential replacement function, such as thyroxine. We need to make sure that drugs that are there to prevent rapid symptomatic decline, such as for Parkinson's disease or heart failure, are also not stopped without discussion. And here, if you use the tools such as stop-start or BIAs, they may flag some of these medications, but in certain situations, it's important that we don't stop them taking the person-centered approach. Is the person taking any unnecessary medication? So this is where medication may have had a temporary indication. We're now on higher dosages than usual maintenance dose, so where treatment has been given and it hasn't been reduced down to maintenance dose. And thinking really about the drug efficacy table and the applicability to the individual you have in front of you. So the drug studies may have been done in a much younger population without comorbidities, and it's about making that judgment using the numbers needed to treat drug efficacy tables. So essential treatment is the asthma treatment here. We know it's suboptimal. We need to check the technique, but we also need to maybe think about, is the lady developing signs and symptoms of chronic obstructive airways disease? We know that she's a long-term smoker. So again, it's about checking that as well. Identifying unnecessary treatment, and this identifies where there are the opportunities to deprescribe, to stop and reduce some of the medicines. In here, we have a few illustrated, so the treatment dose of PPI, the proton pump inhibitors being used. So aiming for a low dose and making sure that we have a slow titration to prevent rebound acid reflux. Pain management, We know that there's a combination of painkillers being used here, but gabapentin is not indicated because there's no neuropathic pain indicated here. So again, thinking about reduction. And this is true also for insomnia, taking long-term zopiclone, and the side effects are going to be exacerbated, particularly when it's taken with analgesia and medicines for depression. So again, review the medicines that's being given for depression and think about support and the need for the long-term treatment here. And we know that for Mrs. P in this scenario, that some of these treatments may be indicated, but we need to have that conversation. So deprescribing really is about stopping or reducing medicines that may no longer benefit a medicine and have an increased likelihood of harm. And we need to therefore think about the numbers needed to treat when we're making that assessment. So these are only estimates, and so we need to think about what the numbers needed to treat are and how that relates to the individual, with the ideal numbers needed to treat being 1. So always think about the numbers needed to treat and what's the benefit and the risk so that we can make that judgment. The numbers needed to harm is often a figure that's helpful to try and identify how many people need to take the medicine to cause harm. However, this data is harder to come by because it's often not collected in the drug studies, or it's not what the studies were there to do. So in here, the larger the number, the safer the medicine. So just the converse that we had. So to illustrate the numbers needed to treat, if we think about people that are taking an ACE inhibitor for secondary prevention, 280 people need to take it for 1 to benefit. However, if we think about it for mild heart failure, it's 30. And if we think about it, therefore, for severe heart failure, the number goes down to 8. So you can see by thinking about the numbers needed to treat the individual, it will help inform your decision about the appropriateness or not of the medication. So step 4 is, once we've decided that we're going to prescribe the treatment, it's thinking about, is it being effective, and do we need to adjust the treatment here in order to assure the therapeutic objectives are being achieved, for example, clinical targets, or prevent any exacerbations. And we have a few areas here for Mrs. P. Pain control not being effective, but really thinking about, well, what are realistic expectations around pain management? Insomnia control, smoking cessation, and asthma control. So thinking about reviewing all of these areas. Step 5 is really about preventing medication-related harm and thinking about the impact on drug disease and drug-drug interaction, particularly when you have altered effects of pharmacokinetics and pharmacodynamics. And the list you can access here of high-risk medicines, and these are medicines which, when used inappropriately, are likely to cause increased harm. Examples include anticoagulants, platelets, CNS drugs, and antibacterials. And you can find a more comprehensive list in the article that's highlighted here. So thinking about this lady here, the actual side effects that are being caused here are the drowsiness with the zopiclone, the tramadol, and the gabapentin, which can impact cognitive impairment and affect activities such as driving. They can also cause dependency and have an increased risk of overdose if they're accidentally taken in higher combination. So empowering patients also is important here in terms of preventing harm. So when a patient becomes ill, some medicines, particularly combinations such as the triple whammy, ACE inhibitors, diuretics, and metformin, can cause increased harm. So making sure patients understand what to do when they become ill to prevent issues such as acute kidney injury. So step 6, we talked about preventing expensive medicines and using medicines that might be generic or alternatives that may be more cost effective. So thinking about the opportunities to use for this lady. And finally, thinking, coming right back to the patient, making sure that they understand the treatment and that they are in agreement with that, given the data that we have on adherence. So poly pills will have a place, but only a place if we've got the medication and the treatment right for the individual in the first place. So making sure that we agree and share the plan with all the different people that are involved so that we have a coordinated, holistic approach in order to manage the treatment. So I hope that you can see here, that then looking at the patient preferences is really important. So we may have to prioritize the asthma management and then come and deal with pain management and medication reduction in order. So working with the patient and what their preferences are in order to get them engaged and agree to the plan that we need to take forward here. So this, I hope, illustrates how a person-centered approach can be used to make sure that the approach is coordinated, making sure that we undertake and do this at each transitions of care. So as the patient moves from care setting, or it may be from moving from ward to ward. And I'm happy to take any questions that you may have. So thank you for listening.
Dear colleagues, good afternoon. It is my pleasure here to present you the following topic. As you can see on the slide, deprescribing dilemmas, how to approach hypnosedative deprescribing in older fallers. As we all know, benzodiazepines belong to one of the most frequently prescribed drug classes. You can see that the prevalence of use both in the community and in the institutional setting is very high. Despite the recommendations for rational use of benzodiazepines in older people, which indicate that preferably intermediate acting benzodiazepines should be used, that the use should be limited in time, that a combination of 2 or more benzodiazepines at the same time should be avoided, and also the combination with other psychotropics should be avoided. And also that the recommended daily dose should be rather low. That's why benzodiazepines belong also to the drug classes which are correlated with a very high fall risk. As you can see, in comparison with other drug classes, psychotropics in general and benzodiazepines in particular go along with a really high and the highest fall risk score. Besides that fall risk, higher fall risk, there are also some other particular aspects in older adults which are incorporated in a higher risk of chronic use of benzodiazepines, and these are decreased consciousness, confusion, motoric disorders with high risk of falls and fractures, memory and coordination disorders, slowed learning process, and also respiratory depression and hypercapnia. The current evidence-based fall prevention strategies indicate that there are several aspects that should be taken into consideration when addressing the use of psychotropic drugs and benzodiazepines in daily practice. These evidence-based strategies recommend systematic medication review and also adaptation of the medication list with the intention to minimize use of high-risk medication, in addition to vitamin D supplementation, and also, which is very important, consumer or patient education. If we take the aspects of deprescribing within the amelioration of medication list, then we have to address the following aspects. The possible limitations of the studies available on drug use at the moment. Also, the priorities of the older person should be taken into consideration, and preferably a comprehensive assessment of the older patient or older person has to be applied. Also, strategies to help deprescribing are very welcome, and certain attitudes of both prescribers and the patients are, of course, necessary. And at the end, also the barriers and facilitators of the prescribing process and undiagnosing have to be known. The aspect of first benzodiazepine prescription is also an important one, and the patient perspectives have to be taken into consideration. It is known that patient use The following two strategies to justify their chronic benzodiazepine use, namely maximizing their problems and also at the same time minimizing their use of benzodiazepines. Moreover, patients tend to place the responsibility of prescribing benzodiazepines on their prescribing physicians because the patient think that situation is beyond their control and possibly they prefer to transfer responsibility to their physicians. A short comment with regard to personality traits and socioepidemiological status of older benzodiazepine users. You can see on the slides, they are often widowed females with dysthymic disorder, anxiety, predisposition to alcohol dependence, and also borderline disorders. There are also certain barriers to discontinuation of chronic benzodiazepine use in daily practice, in particular in older nursing home residents. And as you can see they include perceived effectiveness of benzodiazepines, the absence of side effects, and also presence of dependence, both psychological and physical. When we would like to opt for withdrawal from benzodiazepines, these aspects have to be taken into consideration. First of all, a review of benzodiazepine medication with also thereby initial reasons for use, type of benzodiazepine, response to benzodiazepine, also patterns of use, continued pattern or intermittent pattern. Also, the appearance of side effects is very necessary to be reported, and also current or past withdrawal history and symptoms. Also, the whole medical history is very important, including concurrent medical problems, mental health history, and also the use of other concomitant drugs and alcohol is important. Of course, different options have to be discussed with the patient, including risk of continued and prolonged use, in particular risk of falls when it comes to older population, and also withdrawal potential risks and management options. So far, there are no uniform recommendations in the literature with regard to optimal duration of withdrawal program. So what we can find is a variable withdrawal period ranging from 2 to 12 weeks. And what is also very much important is the motivation of the patient. And also we describe in the process of deprescribing so-called stabilization period and finally withdrawal period. What we know from the literature is that the evidence so far is rather scarce with regard to deprescribing of benzodiazepines among older people. We were involved in a systematic review which included 7 studies of benzodiazepine and also Z-drug withdrawal. And the conclusion of that systematic review was that the current evidence showed that benzodiazepine withdrawal is feasible in older population, but the withdrawal rates vary according to the type of intervention, and also as the benefits and sustainability of these interventions are unclear, further studies should have to be conducted to assess this. So to summarize, the deprescribing is possible, but the evidence is scarce, and there are still a lot of differences with regard to the preferred approach. As I already mentioned, the aspect of comprehensive geriatric assessment has to be taken into consideration, taking into account the comorbidity, the physical and mental status of the patient. Also, the whole medication list has to be assessed and be taken into consideration. In addition, functional status, including risk of falling, is very much important and has to be addressed. And also, I would say the cognitive capacity of the patient is very important. The ability of the patient to take the medication to discuss the possibility of withdrawal and also the risk of delirium after considering deprescribing has to be taken into consideration. Also, social and economical situation and also the life phase, in particular palliative phase, have all together to be taken into consideration. Also, sensorial limitation and compliance in general are important when discuss pharmacotherapy. When we speak about approach to polypharmacy in complex older people with multimorbidity, these steps have to be undertaken. We start always with medication reconciliation, followed by pharmacotherapeutic analysis. Thereafter, we apply pharmacotherapeutic discussion, searching for medication which is not appropriate in a very particular patient. And finally, we apply pharmacotherapeutic plan, which include the amending of the current medication list. So what is the purpose of medication review? To try to link every medication to the patient's comorbidity, to see are there any comorbidities which are not treated, are there comorbidities which are not treated effectively, and are there medications for which there is no indication. And finally, to screen for possible drug-related problems per medication the patient is taking in order to maximize efficacy, minimize risk, and also minimize costs with respect for patient preferences. For the sake of time, I will just briefly mention that for the moment there is good evidence that collaboration with pharmacists can decrease the risk of drug-related problems within the aspect of medication review, but the evidence is still lacking with regard to the effect on health-related outcomes. There are many tools in the literature that can be used for medication review and also for the assessment of the quality of prescribing, which are divided in an explicit tool limited to the medication itself or to diagnosis, and implicit tools which take the whole context of the individual patient into consideration. Here on this slide, you can see briefly some of the most frequently used both explicit and implicit tools. Stop-fall is one of the tools, one of the explicit tools, which has been proposed in the literature with regard to 14 medication classes that include medication with increased fall risk. And what is important for this presentation, that this tool apparently indicates psychotropic drugs as drugs with very high fall risk. As you can see on these slides, within the Delphi panel, among answers whether a stepwise withdrawal is needed in general, as you can see, psychotropic drugs and benzodiazepines in particular were indicated as one of the classes where stepwise withdrawal is certainly needed. And on this table, you can see the aspects like fall risk assessment, stepwise withdrawal, and monitoring after the prescribing with regard to benzodiazepines. So fall risk assessment has to be undertaken in case of daytime sedation, cognitive impairment, or psychomotor impairment, and in case of both indications, sleep and anxiety disorders. With regard to stepwise withdrawal, in general, it is well needed, as we indicated, and monitoring after deprescribing include, in particular, anxiety, insomnia, and agitation symptoms. Currently, we are involved in the producing of world guidelines in fall prevention and management for older adults. It is a global initiative, a very, I would say, ambitious project. And as you can see, there are several recommendations, and as indicated on this slide. So it is important to assess for fall history and the risk of falls before prescribing potential fall risk increasing drugs. Also, a medication review including these drugs is performed regularly. We also recommend the use of validated structure screening and assessment tool to identify drugs which increase the fall risk within that aspect of medication review. And we also recommend that the medication review should be performed in conjunction with a holistic and multifactorial approach to stratify for overall fall risk. Furthermore, we recommend that judicious deprescribing of fall risk increasing drugs should be part of the multimodal and multifactorial fall intervention in older people. And moreover, recommend that deprescribing of all risk increasing drugs should entail a patient-tailored strategy. So there is no standard, I would say, one fits all approach, but the strategy should be patient-tailored. Furthermore, we recommend that in certain situations, deprescribing of all risk increasing drugs can be considered as a single strategy. And there are some practical tips. When available, use tools for assessment of the appropriateness of prescribing, such the tools that we already indicated, but among them, in particular, stop fall explicit tool. If you are a clinician assessing patients regularly, ensure that the patient chart is flagged at the appropriate times. Point to indicate that the medication review is necessary during the visit, and that the medication review includes also reviewing these fall risk increasing drugs. The comprehensive geriatric assessment, as we already mentioned, is preferably applied as it takes all relevant items and allows also a patient-tailored approach. And for successful implementation of fall prevention and judicious deprescribing, education of both patients and healthcare providers is essential, thereby including patient in so-called shared decision-making, sharing the responsibility and discussing the best possible options for the individual patients. Furthermore, to end by this, for successful implementation of deprescribing intervention to reduce risk of falls in older adults, education of patients, family members, or relevant care providers and healthcare professionals is really essential, because we really opt altogether for shared responsibility and also, I would say, well-discussed decision during the process of deprescribing. And also long-term success of deprescribing can be increased by provision of monitoring, support, documentation, and I would say education of both patients and their caregivers. And this is the last slide, and hereby I would like to thank you for your attention. So it was not so easy to comprehend such a topic within 15 minutes, but I hope that I succeeded to give you the most essential information. Thank you for your attention.
Maybe I can ask the question of Alessandra Graziana. Thank you for your enlightening talk. I have a brief question. If you identify more than one drug in a falling patient, I suppose you start by deprescribing the least necessary and the most related. But if the strategy doesn't work and the patient keeps on falling, how long do you wait to proceed with deprescribing another drug, assuming failure, your first choice? Well, if I may start this in the discussion, this is indeed a very important point. Usually, there's many drugs that a very older person is using, and especially older fallers. And so the first drug to choose would be the one with the highest fall risk for that particular person. And if there are several, then you would choose the one that has the, well, that fits best with the goals and wishes of the patient. Or of course, if there isn't an indication, but then you should stop anyway. And when you start deprescribing, you need to take into account the time it would take for a drug to work or for a drug to stop working. And to see an effect, some things would be seen immediately, like if it would be orthostatic hypotension in a diuretic, after a few days, they should have less symptoms. But if we're talking, for example, deprescribing antidepressants, again, depending on the problems you have, the sedativeness should go away after a few days. But if you want to also take into account of the symptoms that might reoccur, you would need to take more time, and it would be several months where you decide whether this is the right choice or you need to readjust. But to go back specifically to stopping, to going to the second one, usually I take 1 or 2 weeks for a drug withdrawal to take effect, and then I have my discussion with the patient, and then we go on, or we may do it in steps, but let's say we just stopped, and then if it doesn't work, we discuss if there would be any reason why it didn't work in the first place, because sometimes they don't stop right away, for example. And if that isn't the case, then it would be the next drug. But again, as everything in medication review and deprescribing, it is really a personalized thing. Maybe ALPANA, do you want to add something there on the general side of deprescribing?
Yeah, no, thank you, Nathalie. I would agree with everything that you said, although I think sometimes there is a bit of negotiation with the patient, and that's where the shared decision making comes in, because although one drug may be more likely to be contributing to the falls, if you have a basket of them, sometimes it can be that actually you're able to negotiate. They stop one first, they get a bit of confidence, and then you can move them on to the other one. And it picks on what Mirko was saying, that it's quite focused on the individual, making sure that we have that conversation, because they're going to take those decisions away at home and implement them. And if we want them to sort of engage with us and work with us, we also need to sort of ask them what the views might be. And the shared decision making tools, really making patients an active part of that decision, are more likely to sort of lead to the outcomes we want. So thank you.
Yes, I very much agree. And Mirko, may I ask you, with regard to deprescribing benzodiazepines, what are the timelines that you take for deciding whether a deprescription was effective on limiting or lessening side effects?
Well, I think it's very important, Nathalie, to mention several things. Already before starting the prescription, I think we should have a tentative stop date in our mind and discuss with the patient I would say the preferred duration of the therapy. The longer the duration, the more difficult the process of deprescribing would be. Of course, the dose of the drug plays also an important role. So these are the elements that we always have to take into consideration when tailoring the deprescribing process. But also, as I indicated in the presentation, the motivation of the individual person or individual patient is really crucial. So that already in the beginning we have to kind of agreement with the patient before starting the process of deprescribing. So these are the elements which might influence the success rate of deprescribing. And what we can say from our experience and our research, that about 1/3 of successfully deprescribed patients remain medication-free after 1 year.
Okay, thank you very much. I think given the time, we have to finish our Q&A session, but of course, we're very willing to answer things by email or other ways if you have further questions at some other occasion. Thank you very much.
Thank you. Bye-bye.
Thank you. Bye-bye, everyone.